Good afternoon, everyone. My name is Karen Houseknecht. I am professor and associate provost for research at the University of New England, and I am delighted to welcome each of you to today's discussion on scientific literacy. You know, it's hard for me to imagine a more timely or relevant topic for our discussion as we come together as a group of educators, healthcare providers, future healthcare providers, scholars, community members, and family members. This is a topic that is impacting each of us, likely in multiple ways, every day, and certainly since the start of the SARS-CoV-2 pandemic. I'm so pleased that we have joining us today a panel of experts who will share their experience, insight, and evidence relating to this important public health challenge. I encourage each of you to join in and participate in today's discussion. So again, welcome to today's event, and I will now hand it over to Dr. Shelley Cohen-Conrad.
Thank you, Karen. I'm delighted that everybody is here on this very important topic. It's our last CC event for the fall. Our poster session is next. I want to do a very quick thank you to everybody who helped with this event. We had the CC's Campus to Community Advisory Team, Maine Health Institute for Research, and the Association of American Medical Colleges, all of whom made this event possible. Before we begin, I want to remind everybody that this topic will bring forth a diversity of opinions about health protocols and particularly around the vaccine. And we will be going into breakout rooms later, and we will be part of the chat later. And so I'm just hoping that everyone's comments and questions will be thoughtful and respectful. And now to our panelists. Jennifer Gundler is the director of Maine's AHEC here and in Maine, and a public health educator for UNE. And my favorite line from Jen's bio is that I came into public health by failing chemistry. And so Jen is a fantastic speaker, and she'll be opening our event today. We then have Liz Jacobs, who is Vice President for Research at Maine Health Institute for Research, and Christopher Pizzullo, who's a graduate of UNE-COM, and he serves as Chief Clinical Officer for the Maine Primary Care Association, and Kevin Olson, who is a PA in emergency medicine. And lastly, but of course not least, we have Jennifer Heyman, a pediatric hospitalist at the Barbara Bush Children's Hospital and Maine Medical Center, and primary lead on a double AMC grant that explored vaccine hesitancy. I'll be joined today by Natalie Gray, who will be helping in the chat. Natalie's a public health student. And then finally, I want to thank all the people who helped to put this together: Liz Verda, Emily Ferry, Aileen Longsod, and Catherine Simmons, both from the Rue Institute. And of course, the amazing CC team of Michelle, Chris, Dave, and Lee, who always make great things happen. So I'm going to go to Chris, who's going to take care of our poll, which is going to start our session today. And would you like to give the instructions, Chris?
Thank you, Shelley. If you want to participate in the poll, please hold on.
Yeah.
Thank you, Shelley. If you want to participate in the poll, please scan the QR code with your phone or follow the link, which will be in the chat. Michelle, if you could put the link in the chat, or open the app on your phone that you already have and look for UNECC. We're interested in finding out what scientific literacy means to you.
And we look for, oh my goodness, we already have some really cool responses in there. And I'm kind of surprised, in the very middle is ability. And I invite the panelists also and others to comment on what you're seeing here. Understanding data is pretty big. I think our scientists will love that. Evidence. Other comments: aware, comprehension, trustworthy.
I was intrigued by interpret, Shelley.
Yes. I was intrigued by that as well. I thought that was a very interesting
Oh, yeah, both praise here. Good. Excellent.
respect. Nice. We love to see this grow. We love to see folks thinking about ahead of time what we're going to hear. And, this reveals your thoughts, but it also reveals your assumptions. This is wonderful. Keep going. Information is gaining speed here. And data. Okay. This is beautiful, but we've got a lot of talk on the panel. So, Chris, I am ready to close this poll, and it will be available to those of you who are interested in what we came up with. And now it's my pleasure to pass it on to my colleague, Jen Gunderman.
Hi, thank you, Shelley. Thanks for inviting me to be part of this panel. I'm going to do just a brief introduction. My name is Jen Gunderman, as Shelley has mentioned. I'm the director of the Maine Area Health Education Center, otherwise known as AHEC, housed here at the University of New England. My background and training is actually in infectious disease epidemiology. And I mention that because I think that's supposed to give me street credibility to be part of the panel. My job in starting off the panel today start our discussion is with some explanation of key terms. But first, I want to thank Natalie Gray, who is a public health undergraduate student and helped me to put together some of the information for my presentation. Next slide. Let's start with the concept that has brought you here today, scientific literacy. As with most health topics, a bunch of committees and working groups came together to develop this definition of health literacy. It is the understanding of the scientific processes and practices, the familiarity with how science and scientists work, the capacity to weigh and evaluate the products of science, and the ability to engage in civic decisions about the value of science. Scientific literacy is a complex term, and while the individual knowledge is at the core of this term, scientific literacy is impacted by community and society. When we think about community norms and values, that heavily influences a person's knowledge. Scientific literacy actually starts at a young age. Have you ever been around a preschooler who asks a litany of questions? Why do leaves change colors? How does the plane fly? Where do babies come from? Right? This curiosity is the building blocks of scientific literacy. Next slide. Now, the next term I want to introduce you to is health literacy. And oftentimes health literacy is interchanged with scientific literacy. But health literacy has a little bit more nuance to it. I like this definition because it highlights the fact that health literacy is more than someone's reading ability. And when I look at the poll and the words that came up to highlight around scientific literacy, between scientific literacy definition and this one, I see a lot of those words in the more formal definitions. So health literacy entails people's knowledge, motivation, and competencies to access, understand, appraise, and apply health information for that decision making. What I think is really important about this definition is that particularly as health professionals and public health professionals, we have to remind ourselves that health literacy is more than just telling a client, a patient, a community a fact about health and then expecting them to change behaviors to what we would consider more healthy ones. One example of the relationship between scientific and health literacy, one that I find fascinating, comes from us from the 17 and 1800s and the miasma theory. This was a theory to explain disease transmission. And based upon this theory, polluted or poisoned air was seen as the primary source of disease transmission. Malaria literally means unhealthy air. As we know, malaria is not transmitted through unhealthy air. And yes, air can transmit disease, but we know now, based on scientific discovery, is that there are other ways that disease can be transmitted: vectors, direct contact, fecal oral, etc. This false miasma theory was based on limited and poor scientific literacy. And this resulted in unhealthy personal health decisions and unsanitary living conditions. Next slide. Our literacy is dependent upon many factors. One is the actual information that we are accessing, appraising, understanding, and applying. And this leads us to understand two important terms. The first one being misinformation, which is the sharing of inaccurate and misleading information in an unintentional way. This is like playing operator with our friends when we whisper that first phrase and it gets to the end and it's not with what we started because something accidentally changed along the way. Disinformation is the deliberate dissemination of false or inaccurate information in order to discredit a person or organization. This is, again, like playing the game operator, where someone intentionally changes the information that's passed along. Now, disinformation, factors that motivate people to create and share disinformation, sometimes is due to financial gain, political power, and sometimes just experimental manipulation to see what will happen if misinformation is spread. Now, this spread of mis and disinformation has evolved in what is being coined the term infodemic. An infodemic, as defined here, is too much information, including false or misleading information in digital and physical environments during a disease outbreak. This mis and disinformation causes confusion and risk-taking behaviors that can harm health. It also can lead to mistrust in health authorities and undermines the public health response. This term was first documented by a journalist who was describing the rapid amplification and replication of mis and disinformation in 2003 during a SARS outbreak at that time. And that journalist at the time said this amplification and replication was due to modern technology. May I remind you, in 2003, this was before the sort of emergence of social media messaging and messaging platforms. Next slide. I love this depiction of how infodemics spread. We've sometimes have seen this figure. And so this is just my creative way of showing how an infodemic happens and spreads. Next slide. So infodemics is not the sole reason, but has significantly contributed to vaccine hesitancy. Again, a committee came together to devise this definition of vaccine hesitancy as a delay in acceptance or refusal of vaccines despite available services. It is, again, a complex and context-specific, varying across time, place, and vaccine. This is not a binary term. It is not pro and anti-vaccine. People can fall along the spectrum. Providing accurate information and correcting mis and disinformation can move people closer to demand, or the proliferation of mis and disinformation can move them closer to refusal. Next slide. So, as a public health practitioner, infectious disease epidemiologist, I leave you with my part of the panel with the notion that addressing infodemics should be approached like anyone would an outbreak to a sort of traditional disease. First, by collecting ongoing data. By doing this, we identify increased rates of the spread of mis and disinformation. There are many examples across the globe of creative ways to collect this information. That infodemics are approached with urgency, that it becomes a priority in public health. And when that happens, we're able to devote the resources such as time and people to investigating, solving, and ending the outbreak. It's about asking questions to understand the who, what, where, risk and protective factors associated with the outbreak, and involving partners. When we think about infodemics, it's involving non-traditional public health and healthcare partners like social media platforms. And lastly, we need to implement immediate strategies to control the spread of this pathogen not a bacteria, not a virus, not a parasite, but mis and disinformation. So I hope this part of my panel has helped to really kind of clarify some of the terms that we'll be continuing to talk about in this panel and with our conversations and breakout. I now hand it over to Liz Jacobs.
Hi, good afternoon, everyone. As we said earlier, I'm Vice President for Research at Maine Health and the Director of the Research Institute there. I'm also a primary care physician, primary care internist, and so speak a lot to people about vaccination, and so very interested in this topic, both professionally as a physician and as a scientist. So I'm going to talk a little bit about some qualitative data that we've collected as I'm representing a team here in my presentation that I will show you who are the members of those team at the end about COVID-19 vaccine hesitancy in Maine. So essentially, as you all know, there are very distinct and large disparities in who dies from COVID-19 in rural versus urban neighborhoods, as well as who has access to or has elected to receive the vaccine. And as you can see here, those areas that are not green are areas where there's less uptake of COVID-19 vaccination. So we wanted to understand, to think about how could we message and work with people within the state of Maine to move them closer on the continuum that Jen just described towards getting vaccination if they were hesitant about it or very concerned about it. So the best way to do that is really to ask people who are affected and who you want to reach. And so we undertook a qualitative vaccine hesitancy study in which we interviewed people one-on-one about what were their approaches to vaccine, what they thought about it, what motivated them to get the vaccine and not. And we wanted to work with 3 community partners because, as was discussed earlier, and you'll see in these slides, there's actually significant distrust related to this vaccine. We felt it was important that people within communities invite other people to participate. So we worked with these 3 community partners. We conducted these semi-structured interviews with 17 adults. It was done between March and May of 2021. And we used this framework analysis to understand what were people saying within the different groups we identified, which I'll show you in a minute. As you can see, most of them were female, most of them were white, most of them had a graduate college degree or higher. Average age was 58. And not surprising for the state of Maine, more than 50% of the individuals identified their political party as being an independent. So we identified these 4 thematic groups. So on your left, you can see more than hesitant, and you can see there's only a small group, which I'll talk about in a minute. As this person said, who's in this group, oh yeah, and I've told them they can shove it where the sun doesn't shine. Hesitant but open, I'll look what is available for the information and then go from there. But in all honesty, I'm probably just going to do it at some point. Formerly hesitant, I wasn't going to get it at first, probably because I had the same fears as everyone else, but then I guess I changed my mind. And many of us are probably represented on this call. Not hesitant, I always told everyone as soon as I will get that vaccine. We're going to focus on this hesitant and formerly hesitant group because we believe that those are the messages that can actually move people along the continuum. So what you can see is that for those people who are hesitant but open, there are 2 things in red that indicate sort of what was holding them back, what was creating hesitancy. And then in the blue is what was moving them towards the vaccine. So as you can see, people were concerned were hesitant if they didn't think that they were at risk of COVID. So this person said, eventually everyone should get it, but right now the older people need it. I'm young, I'm healthy. I'm not going to really have a problem with COVID, so I don't need to get it. The second thing was perceived vaccine risk is high. With any vaccine that's rushed, there's the way this one has been, I feel like there's going to be some kind of major impact on the road that we haven't become aware of. So one thing I would just want to point out is this is actually a scientific literate comment, right? One thing that we want to evaluate when we're looking at research and something applies to us is how carefully was someone put together. One thing I would say we didn't do very well is communicating. Even though it went fast, we did all the right things. We were just speeding it up because there's a bureaucracy to getting these things approved, and we kind of sped up that bureaucracy. And then back to normalcy. This is what people motivated people. I feel once I have the vaccines, I can go back to other things. I can go to work. I can see my friends. I can visit my older relatives. Here are the key findings for formerly hesitant. People want to talk about protecting their community. I feel like vaccinating is kind of more like a selfless thing for me to do anyways, because I'm young and healthy. You know, for me, it's about protecting other people. And then there's conversations people had, and I think this is really important for the people who are in the health professions on this call or going to be a health profession, that a conversation with your physician can move you. This provider just offered a bunch of information ahead of time. It was just like we're having a conversation, and they asked me how likely was I to get it. Am I completely against it? Reasons why for a guess. And then they just put it out there. And then that conversation helped me move along. They answered my questions. And then conversations with others. You know, everybody around me was getting it. And I'm like, I'm just going to wait and see how it goes and see if anyone in my office gets it. And as everyone was getting it and they weren't having immediate side effects or any problems, I decided, okay, I should go along and get it as well. And as I said at the beginning, some key findings here were related to trust. So people who went ahead and got the vaccine, as well as were not hesitant at all, really had a lot of trust in science and medicine and medical authorities. As you can see from these 3 quotes, someone said, I always wonder if they go through all the right steps, but it's out of my hands. I'm just going to have to trust that they're doing it right. I put a lot of my faith in people who know what they're talking about. If they know what they're doing, I'm content. And I trust that the providers aren't going to give us a vaccine that hasn't been properly studied in the United States. So that demonstrates the trust. But then, as you're all aware, there's significant distrust, both in vaccine producers and politicians, as these 3 comments reflect. 1, I don't have a lot of trust in the pharmaceutical companies anyways. They're not doing it to benefit humans. They're doing it for profits. Politicians are going to screw the people any way they can. That's their job. See, they think something's good for us only as long as they're lining their pockets. So profit motivation. And I really have a hard time trusting people that are saying, oh, well, we only developed this over the past couple of months. Go ahead and try it. So what are some of the limitations of the study? We really had difficulty recruiting hesitant participants. And unfortunately, the way we actually invited, I think this basically demonstrates the polarization around vaccines, in that we were like, we are interested in your opinions. We don't want to convince you. We're just really interested in why you've made your choice. And we really respect that choice, but really want to understand why. People still who are hesitant or not going to get the vaccine at all still did not want to engage with us. There was, during that time, and still is, the evolving nature of the pandemic. So what might happen now, especially now that it's been several years since we've had the vaccines available, and a lot of people have received it, and there hasn't been the side effects some people have been concerned about, that some of this may not apply. But what we concluded, the relevant threads for messaging are around trying to address the concerns that COVID risk, or not the concern, but the belief that for some people, the COVID risk is acceptable and that the vaccine is unacceptable. So how do we use scientific literacy in the way we speak to people to help them understand that? Motivators, helping people understand the motivators. It's about other people. It's about senior grandparents. How can you help them get to that place? Really focusing on these personal relationships, you as a physician, you as a sister, you as a friend, and building community trust is really important. And I just want to end by thanking the National Institutes for Health through the Northern New England CTR pilot grant that's funded this, and the wonderful team that you see represented here that contributed to all this work. And I'm going to end, and I'm going to pass it on to Chris.
Thanks so much. And thank you to the UNE team for inviting us for this day. I wanted to first just do a brief intro. I am a Unicom alum, class of 93. I'm also a pediatrician. 2 days a week, I work as a pediatrician at Mercy Northern Light. 3 days a week, I'm the Chief Clinical Officer at Maine Primary Care Association. That's the member organization for federally qualified health centers in Maine. So I wanted you guys to think a little bit about the pandemic and how it might have impacted a primary care provider, in this case, a pediatrician. How much do you think it changed our workflow? So if you remember, not too long ago, in spring of 2020, we had our first cases of COVID here in Maine. And when that happened, there was a sense of urgency, there was a sense of fear, maybe impending doom that came over us. The health systems in Maine decided that we needed to really try to stem the spread of this virus. So one of the things that Northern Light did was they said to us as pediatricians, you can't have any patients in your office who have colds, fevers, any sign of respiratory infections. Think about that. Think about what pediatricians see normally. Besides well visits and camp physicals, they see sick kids. So what wound up happening was that all of the sick kids got sent to an outdoor respiratory tent at our Westbrook facility. Our office is in Portland. So patients were confused. They had to be cohorted and maybe almost corralled into an unusual medical setting for them. And we really weren't allowed to start seeing patients with respiratory illnesses until last fall. So for over a year, we added telehealth to our armamentarium. We started doing well visits by video. And I'm sure for those of you who are in a comm program, you're told that the physical exam is the most important. You have to listen to your patient. You have to touch your patient. Well, now they're on a screen in front of you. Certainly, this was driven not only by a need to prevent the spread of infection, but also because, if you remember, there was a huge gap in availability of personal protective equipment. So they started telling us, since there were no supplies available, well, you can reuse your N95 multiple times. It's probably okay. Then if we couldn't find N95s, they said to us, well, we're going to try to give you ways to sanitize or sterilize your N95, or you can just use surgical masks. When the health system heard this, they were like, okay, this is really not safe. This is not possible. And remember, we had routine offices that did not have reverse flow necessary for preventing the spread of infectious diseases. So some of the things that happened, I think, to patients and to us was that patients got behind in their routine vaccines, sometimes a year or 18 months behind in vaccinations. We also, I think, adult providers of primary care and adult medicine saw this even more. But for patients with chronic medical conditions, there was a delay in care. There certainly were delays in surgery. Many of you guys may have experienced that yourselves, where non-emergent surgeries were put off for maybe 6 months, maybe a year. So I just wanted to give you the flavor of sort of what happened to primary care during that time. Obviously, we know we're no longer masking now. We have vaccinations that are available. We feel comfortable that those vaccines were developed in a safe and trustworthy way, and they are supported by our medical organizations. I did want to slowly ask you a few questions just for you to think about, so maybe we could talk about it at the in the small groups before I introduce the next person. But I just wanted you to think about how you might respond when you said to the parents of the children in your practice that you would like to vaccinate them against COVID. And here are the questions. I'm going to say them slowly in case you wanted to write one or jot one or two down to think about how you might answer. So what would you tell a parent who says that they're not going to vaccinate because there's already a state vaccine mandate for school entry? That's enough vaccines for my child. I don't want to give any more. Or how about I'll rely on the rest of the population to give shots to their kids. I've heard that provides herd immunity. What about this vaccine is too new for me to use it yet? I don't want my child to be a guinea pig. What if your patient said, I'd rather play the odds. Most young kids don't get severe COVID, so I'm not going to vaccinate my children. And then the last question before I introduce our next speaker is, well, this pandemic isn't real, so I'm not going to give a vaccine for it to my kids. We can talk about that a little bit later, but I wondered if we could show the next slide because I'd like to introduce a speaker from one of our federally qualified health centers in Maine. His name is Kevin Olson. He is a PA. He works in both primary care and emergency medicine up in West Enfield. Correct me if I got that wrong, Kevin. West Enfield, Maine.
You're correct.
And he is going to talk to us a little bit about his experiences, both in primary care and emergency room care during the pandemic in a rural environment. Thanks and welcome, Kevin.
Thank you. I'd like to thank the UNE staff for inviting me today. I'm going to try to give you a firsthand perspective of kind of what I went through at the time. Again, I work primary care. I work two jobs, emergency medicine and primary care. I'm going to start with my primary care job. Just as Chris talked about, there was worry. We didn't know what COVID was. So I was pulled. I wasn't allowed to see my primary care. Because I had emergency room experience, I actually helped set up a drive-through triage at Penobscot Valley Hospital, another critical access hospital that Health Access partnered with. And we did a drive-through. I also, myself and another provider, basically saw what we call in a disaster, or a pandemic, the worried well. They may have COVID, they may not, but whenever there's a disaster, there's worried well that really rush to be seen. And so we were trying to take some hit off the emergency room in Lincoln at that time. And so there was two of us that did all the testing. The rest of the providers were sent home. And that's the way I was in primary care for quite a while. And I could only have communication really with my patients through telephone and emails. And that was frustrating for me. I had some training in emergency preparedness and disaster management through the University of North Carolina. So I want to just say that in disasters or pandemics, we learn from the past and we practice in the present and we prepare for the future. You know, this mysterious illness started in 2020 in Wuhan, and we had no idea. So what was the past at that time? Well, the past was, we know in a pandemic, we need surge capacity. What is surge capacity? It's not just beds, it's staff, it's PPE, it's medicines. Did we have enough staff at the critical care hospital in Millinocket or Lincoln? No. Did we have enough PPE? No. So you practice in the present. You practice with what you have. And COVID was learning daily. It was like flying an airplane and building it at the same time. We just didn't know. Initially, these people came in hypoxic, 85%. Everybody else in the world that we would intubate in any other time, they didn't really look that bad. We intubated them. They did worse, okay? We found out that intubating early was not really the right thing. We found out that passive hypoxia was better. The recovery trial from the United Kingdom, which had 10,000 people in it, we found out that BiPAP and Vapotherm work, but BiPAP works better to keep somebody from getting intubated. So they stopped using Vapotherm because they were using up all their oxygen supplies. As things proceeded and we moved forward with COVID, we've now found out that there are several treatment options we can do outside the hospital that are 85 to 88% effective at keeping people from getting hospitalized, such as, Paxlovid, such as monoclonal antibodies, such as remdesivir. However, that's being misused too, and it's indicated for high risk patients. People, there's been so much social media, and that's been talked about earlier today, that people call and they tell you what they want. They're not listening to you about the disease anymore. This has become a pandemic of social media, unfortunately, and it started off that way a little bit, in my opinion. In regards to COVID, I'm giving you more of a frontline approach here. In Millinocket, where I work as a PA, there were 4 of us. There's 4 PAs. We ran the ER. All of a sudden, we don't have staff. We don't have ICU capability. We can only vent 2 patients at a time in our facility. Eastern Maine was full. Other places were full. We didn't have ICU nurses. The vent patients stayed in the ER. All of a sudden, a patient that at any other time in the past 5 years that would be taken care of by an intensivist was taken care of by a PA. And sometimes an internist, sometimes a primary care doctor. We all did what we needed to do at the time. Other things we learned from COVID, we learned that there's many more organ systems involved than just pneumonia. We learned that abnormal blood clotting is a high risk factor. From the New Orleans study, we learned that if you're diabetic and overweight, you're not going to fare very well, probably. But we knew that about other illnesses too. The problem with COVID is you have to use the 4R rule when you're looking of how to treat it, like any other illness. And what that means is the right patient, the right drug, the right dose, and the right timing. We found out that, certain drugs work, certain drugs didn't work, certain drugs work if they're started early enough. In China, we found out that the remdesivir did not, discharge, it did not improve discharge time from the hospital. And from that, it made us rethink things. It made us rethink efficacy and our endpoints. We have found out that, glucocorticoids reduce the 28-day death rate and shorten hospital discharge time. And we found that out in the recovery study, again, from the UK. But throughout all of this, as far as inpatient side, we found out that oxygen therapy, supportive therapy, antiviral therapy is started very early, the first 2 to 3 days. Anti-inflammatory therapy is started very early, the first 2 to 3 days. Sometimes JAKs inhibitors later on are all helpful. So, that takes us through the present. How are we going to prepare? Well, the preparation, I think, is in what people have talked about is the vaccines. That's where it comes about. And we've talked about hesitancy. I tell my patients, Moderna was working on mRNA vaccine 10 years before we had COVID problems, okay? They shared their patent with Pfizer, because they had been working on it for 10 years. Is there hesitancy? Yeah, there is. I had a patient specifically in the ER that needed admission early on in this, that needed to be on remdesivir, and they only wanted monoclonal antibodies because why? The president got them, and he got better in 24 hours, okay? Back to social media.
So Kevin, I'm going to have to interrupt you. We have this presentation is so rich with information that I hate to interrupt you. You provided us with incredible information, as did Chris, about what it looks like in the clinical world. Thank you, and I'm going to pass it on to Jen Heyman now. Jen.
Thank you. Can everybody hear me?
We can hear you fine.
Like Shelley said, I am a pediatric hospitalist, and in the other part of my job, I'm the director of curriculum for Tufts Main Track and work in the Department of Medical Education at Maine Medical Center. And I'm here to talk to you today. My slides are not advancing. Oh, here we go. Thank you. So I'm going to jump in and talk a little bit about a grant that we got from the AAMC, specifically to look at how can we assess and address interprofessional healthcare education to try to improve COVID pandemic outcomes. This is my lovely grant team here. And very quickly, I just want to give a very quick thank you to the AAMC and CDC who funded some of this research. So why we wanted to do this research, I think as it's been highlighted very well today, misinformation and disinformation in the COVID-19 pandemic has increased vaccine hesitancy, as well as it has increased people's willingness to use other risk mitigation strategies to decrease the burden during this public health crisis. And I think we all know that this has led to excess deaths, unfortunately. What we have decided, as has been discussed today, that these become very difficult and charged conversations talking to patients about COVID, particularly the vaccine. And we realized that there isn't really a specific place in a lot of health professions education where people learn a lot about how to address misinformation and vaccine hesitancy. And certainly around COVID, that really has not been present at all. So the AAMC provided a grant that we applied for, and the ultimate goal of the grant program through the AAMC is for interprofessional learners to demonstrate improvements in their capacity to communicate around health information and dispel misinformation as it relates to COVID. So the objectives of our project team that we decided to focus on to achieve this goal first included the importance of establishing an interprofessional working group. So I think we've heard a lot today from all different sorts of people who've been working in this COVID pandemic. And I'm going to kind of bring us home and wrap us up to start the conversation about how important it is to have that interprofessional group working on things. Dr. Shelley Cohen-Conrad, who you've heard from today, was introduced to our team, and we realized that we had a fantastic interprofessional group that was sort of born with that introduction. In general, in medicine, in the medical field, when we think about interprofessional teams, people might think about physicians, nurses, pharmacists, etc. But my team really said we are going to define interprofessional as also including social workers. And we think that was really important because both the literature and kind of in our daily lives, we are seeing that the impact that culture has on how people feel about vaccines and how they feel about COVID in general. It's not just about medical or scientific facts when you talk about COVID. It's about how people interrelate with each other and in their communities. And therefore, we felt that the social work experience would be really rich in helping us understand what informs people to use alternative information as it really relates to COVID. We started by doing a literature review of what was already known. And as Liz mentioned, her group had done a lot of data around Maine-based communities, and we referred to that as well. And then we convened focus groups that included medical students, PA students, social work students, and rehab therapy students. And we had great focus groups, and we used a thematic quality analysis program to analyze those focus groups and came out with major themes and drivers to better understand why people were operating with alternative information as it related to COVID. And importantly, in those focus groups as well, we were able to hear directly from the students, interprofessional healthcare students, about what they thought would help improve their learning to better address people about COVID misinformation. Another objective that we had was to contribute to the literature base, just as Dr. Jacobson's team had done as well. In a second, I'm going to show you a screenshot of part of a white paper that we're part of that will be published soon. And that white paper reflects what was known in the literature prior, as well as new and nuanced themes from our focus group work. The final output, if you will, from our grant will be to develop a toolkit that's interactive, asynchronous, that will help interprofessional, not just students, it can be anybody anywhere in their career, to better learn how to confront misinformation. Part of that toolkit will be animated didactic PowerPoint. And the other part will be 2 exemplar videos that show conversations and perhaps better way to approach people using misinformation. One is a healthcare provider and a patient, and the other one is a healthcare provider having a conversation with another healthcare provider in the workplace, and that healthcare provider is using misinformation. There's really not anything in the literature that talks about how to have those conversations in the healthcare environment. So we're really happy to hopefully contribute to that. This is a screenshot that I know you probably can't read, but this is one of the tables in our white paper that shows what to do and say and what to avoid in having these conversations. And there's very specific examples here that can help people with their language when they're talking to folks. But what I wanted to really highlight here, all of this is based on the thematic findings that we found in our focus groups. And I think probably the biggest driver or observation that we heard was what seemed to be a very definite break between people acting as individualists and feeling like their individual rights were the most important thing versus people who employed collectivism and thought that doing the best for the most was how that they were thinking about this. We heard a lot about body autonomy. And as has sort of been mentioned today a little bit as well, the constantly changing recommendations were very frustrating for the general public. I think people had not seen science play out in live time to see that you make a recommendation, you test it, you change the recommendation based on data and go forward. That really lowered people's confidence that the public health organizations knew what they were doing. We learned that specifically with COVID, folks did not care about medical or scientific resources. They went to other sources. And also distrust of something new, as has been mentioned today, worried about vaccine safety, really made people be hesitant. Our providers today, Dr. Pizzullo and Kevin, have talked about how it was like, what it was like in the trenches for those of us seeing patients. And we know that hospitals and clinics were under-resourced, people were burned out, people were scared. And so not only not having the tools to have those difficult discussions, but the logistical implications of that chaos that was COVID made providers unable to have those conversations. And sometimes that might have led to judgmental language, which I think we can all agree doesn't help anybody. We saw that there was a swing in that pendulum towards distrusting science and government. And I don't think we can underline enough, as Dr. Jacobs talked about earlier, the impact of the historical mistreatment of underrepresented populations and how that history of racism continues to cause disparities in both the morbidity and mortality of COVID in marginalized populations. That's telling you my time is up. So the final thing that I will say is also that people really feel like these alternative regimens don't have side effects and they're safer than pharma medications. With that, I will turn it back to Shelley.
So we are nothing but adaptable at CC. So we are going to go right to first asking the panel for your takeaways and listening to each other, what you've learned. And then we have some questions in the chat and we will bring those to you. So Jen Gunderman, you started the panel. Do you have any final comments for us?
I think my final comment might be an obvious one, but this is not easy. Like nobody is saying this is easy and it can be solved with one conversation with your patient, client, or community. And this is about building a relationship with them. And what it also involves is, and I've had to do this myself, is to let go of some of the judgments that you may have about people who struggle with scientific literacy. And that, like in public health, it's you may not see the return on investment in working with patients, clients, and communities, but it's worth it for the long run. And I'd say there's also a lot of really interesting research that's coming out right now around how to address health literacy, scientific literacy, mis and disinformation with communities. So keep your eye on the research that's coming out and support each other.
So I want to jump on that because one of the questions we have in the chat is from Kylie, who asks, what are some tips to have conversations with patients who have had exposure to misinformation or disinformation? And I just will throw that open. I'm Jen G. I'm not worried about you specifically answering that question, but it's a question that's coming thematically. What do you have some tips from your research and also from your clinical experience?
I can start off with a public health perspective. I'm not a clinician, so I can't offer that perspective, but I can say from a public health perspective, one of the things that we're advocating for is not necessarily responding to mis and disinformation with answers, but responding with questions. Where did you get that information? If you follow that information, what do you think would happen? So asking more questions and curiosity and discovery, and to jumping in with thinking that you need to bust the myths is probably one strategy. Another one that I'll just mention, about a couple months ago, there was some research that came out of, I believe it was England, a university out of England, and Google started to look at how could they address some of the mis and disinformation, it's an infodemic in a very proactive way. And then what they looked at was doing very short videos on YouTube, like ads, that just really talked about critical thinking, not addressing the issue specifically. And they did see some movement in the participants who watched the videos, that they were able to develop critical thinking skills to help improve their scientific literacy. So I think proactive conversations just around critical thinking and asking questions more than trying to dispel some myths.
Fantastic. So Jen Heyman, I see you have some comments here.
Yeah, I would just add, I agree with everything the other Jen had to say about that. I think it's, well proven that going down the rabbit hole doesn't work. And I think something that came out of our focus groups that we are really working into the scripting for our exemplar cases that we're making is the need to show humility. And I think certainly I can speak for physicians, but I may speak for other healthcare professionals that we like to be right. And we have studied a long time, and we think that we follow the science, but having that sort of confident attitude in an evolving, ever-changing pandemic is not helpful. And so having that humility to say, I don't have all the answers, like Jen said, you don't have to answer everything, but I've been trained to know where to look for best recommendations, and having that conversation to say, I'm willing to learn with you and let's talk about this more, builds that trusting rapport that's really necessary to move that conversation forward.
Chris, did you want to add anything to that?
I think what I would add is that it's really all about relationships with your patients. I agree that you can't meet sometimes their force or their anger head on. It's really not going to solve anything. And you need to give them a space to be safe with you. So asking them questions, telling them that you will revisit it with them at another time. And I have to say, I don't know what others think about this, but we in our practice do continue to see patients who refuse to vaccinate. There are some clinics that won't, but our feeling is that refusal to vaccinate is potentially a temporary condition, and we're not going to make a permanent decision about that.
Thank you for that. I just want to ask Natalie, do you have a question to bring forward from the chat?
Yeah, so there was one question by Cassie, and she wanted to know how you guys direct patients towards places to find valid information.
Your question is really a good one, because I think the second part of that question was also that, you go to the CDC or you go to some places and they're jargony or they're technical. I have to say, I don't have good places that I direct people. I mostly like to have conversations with people. So to understand what their concerns are, because sometimes we assume what their concerns are, but asking them questions and in a humble way, as Jen said, I think really helps you get at what their concerns are. And if I provide you with different information, would that be helpful or not helpful? Like asking their permission as well.
Anyone else want to respond to that question, Jen? Damon?
Yeah, I think this got really hard in the pandemic because a lot of our usual go-to places like CDC unfortunately lost some credibility during all of this. So I know for myself personally, I had to kind of rethink, well, not sure I can just say, here's the CDC information. And so I think going to most of the health systems in the state kind of amassed their own library, if you will, about up-to-date COVID information. And I think, especially in Maine, people like trust their provider and trust their healthcare system. And so steering people towards the healthcare system's information, I think, was more successful than saying, like, check out the CDC or the WHO and kind of keeping it locally.
Kevin, you had some thoughts.
Yeah, I would agree with Elizabeth on this, is that the way I go about this is I have a conversation, because if somebody is asking something about COVID, I view that as when an addict comes to me and asks for help. I've got a finite line to convince them one way or another, whether they should be vaccinated, whether they shouldn't be vaccinated. And if I choose to not talk to them that day, they may talk to a friend, they may get more social media, they make their own decision. So I try to have a personal conversation with them.
It sounds like relationships really matter in this conversation. And you may not change people all the way. They may still be hesitant, but you're adding new information to their decision making. There's one more question I thought I'd throw out here from the chat, which is, have there been any community engagement strategies to help increase awareness? For example, going to trusted community leaders to disseminate information. And I know in our study, we heard questions about that as well. And Liz, you're nodding too. You heard that as well.
I noticed Jen had her hand up though. Jen, did you want to say something?
Actually, the next question goes exactly into sort of what my response was going to be in terms of, from a public health perspective, what's a source that you can go to. I think dovetails very nicely into the second question in terms of community champions. So I think of, being creative in public health and finding out who does your community go to for information. In some places it's their religious leader, finding out, is that religious leader spreading correct information? And if they are, they become your ally. And that's where you send people to get maybe further direction on where to get that. So I think it dovetails nicely that outside of the healthcare and public health traditional setting is to find those community partners who are giving out correct information and work with them, because that's who people often trust as well too. Their religious leader, their community leaders, organizations in which they spend a lot of time. So I think my response from the last question dovetails nicely with this one.
Great. Others who want to comment on community? We're just about ready to wrap up. Hearing none. Karen, do you and I want to wrap up the session here?
Well, I think this has been a really rich and exciting discussion, and I'm sorry that we have to wrap it up. I think there's a lot more that folks wanted to say and wanted to share, but I want to thank our presenters. I want to thank everyone who participated in this session. I need to remind all of you to be sure to submit your attendance records before you leave today, and also give a pitch for another action-packed hour of collaboration coming up on November 30th, which is the fall semester interprofessional student poster session. This is a Zoom-only event, and you can find more information on the CC website.
Well, thank you all for attending, and I learned so much, and I've talked to most of you ongoing, and it's really lovely to see how the research is supporting each other. So we've got some really important material, and thank you all for being here.